It was the middle of October at 3 in the morning when Carol Whitlock anxiously waved at her husband as he was conveyed to hospital with COVID.
I remember one consultant getting down by the side of the bed and just simply saying, "You've got to fight this."
3 weeks later, instead of staying in a ward, he's continuing treatment at home. An armband monitors vital signs, sending information to nurses. David gets twice daily calls.
I feel quite bright this morning.
Oh, all of your observations are looking really good my end. Have you been checking them yourself with your pulse oximeter?
The last time, about an hour and a half ago, it was about 94.
David is double vaccinated but has non-Hodgkin's lymphoma, so his immune system is low.
Thanks for calling.
You're very welcome.
At home in the virtual ward, he was hooked up to oxygen for 5 days.
When he first phoned me to say would I be able to pick him up when everything was arranged, I was a bit surprised, I guess, and am I going to cope? Is it going to be all right having him at home? Will he get the support that he needs? Will it all be down to me? But actually, as it progressed, all my fears were allayed.
It was another step that you sort of thought, moving out of the security of the hospital. But the more I thought about it, the more I liked the idea. The hospital is brilliant, but it's not like being home, is it?
At the Norfolk and Norwich, equipment's being delivered for more patients to move onto so-called virtual wards. 40 have moved home in total.
It means those patients are not occupying inpatient beds with us. And of course, for most of us, we don't want to be in a hospital bed. We'd rather be at home. So if we're not in need of active nursing and medical care, this is fantastic.
And it also means that you need fewer nurses per patient.
Absolutely. For those patients, the resource intensiveness of the staff we need to run our acute wards is much lower.
David's still breathless, but at home he can challenge himself every day, while a bed is saved for someone with more complex medical needs.
The hospital is brilliant, but it's not like being at home. I think David puts it so well. He was able to leave the hospital early, using some pretty simple technology, continue to be supervised by his clinical team at home. I'm Tara Donnelly. I've worked in the NHS for 3 decades, most of that time managing services in hospitals as a Director of Operations and as a Chief Executive. And I have huge respect for them and the people that work there. If you are acutely unwell, there is no better place to be than a hospital bed. But once you're past that immediate stage of illness, home has huge advantages. You can rest and sleep properly, eat the food that you choose to eat, mobilise effectively, and be with loved ones and your support network. All these things accelerate recovery, improve morale tremendously. Lee Jones is another gentleman who was looked after in that same virtual ward at Norfolk, and he uses a really interesting word to describe it. He says he is indebted to the NHS and the service that enabled him to recover at home with his cats and his grandchildren all around him. He says it's technology at its best and it's game-changing. These, I think, are really powerful words from people about what being at home means to them. My time in the NHS has led me to believe we need to do much more to support that, to help people stay at home with long-term conditions and return there more quickly if they need to go to hospital. Happily, technology now enables us to do that. Either being supervised, as you saw David, with an armband, he was using a pulse oximeter as well, or entering symptoms daily within an app. And I think that during the pandemic, awful though it has been, there have been 4 shifts that have really helped us move towards digital home care. And the first is not a positive one in many ways. It's the fact that there's been a realisation that hospitals are not always very safe places to be. There's the infection risk that people have been acutely aware of during COVID, but there are lots of other issues as well. Hospital-acquired deconditioning is a real problem, and muscle wasting can begin as soon as 24 to 48 hours after admission. It can result in a really reduced functionality, and particularly in older people, that can be permanent. And for anyone living with dementia, being away from familiar surroundings can be extremely problematic. People can lose cognitive abilities and independence, and in some cases that is permanent. They will never be able to return from the place they came from, whether that was home or a care home. And I think these issues are becoming much more real to people, and there's so much we can do to prevent that. And then secondly, overnight, people started interacting with the NHS in totally new ways. Hospital appointments moved to video. Later on, we were all home testing. 27 million people have accessed the COVID pass on the NHS app. And in their daily lives, people have done things differently as well. We've seen a big shift to online, including banking, groceries, from people who had not tried that before. So this shift, I think, is helpful. We hope to be able to use the NHS app as a digital front door to the NHS so people can change appointments, add things to their record in the future. And then the other thing that happened as the enormity of the pandemic became clear was this tremendous urgency and pace. For the first time in my NHS career, things moved fast enough for me. And as the country first locked down in March 2020, I was approached by a clinician running one of the biggest virtual wards in the country with pen and paper and phone calls, and he asked was there any technology that could help them. And we were able to partner that with a pro bono offer we had from a British startup called Humour, and 4 very hectic weeks later, that service was live to its first patients, both in Hertfordshire and in London, and that is the model that you have seen that scaled across the country for COVID. And what was really interesting is that there was this speed, but no corners were cut. All the data sharing agreements and everything else was done correctly, but people were making decisions at the speed of light. Pedro Delgado, who works for the Institute for Healthcare Improvement, I think puts it really well. He says, in the pandemic, we learnt that slow is a choice. And I certainly hope that's a choice we take very much to heart. And then the final shift that I observed is that there was a real openness to what works. So I haven't heard "not invented here," which is one of the real problems with adoption, for about 3 years. The NHS is hungry for new ideas and to put them in place, things that are working elsewhere. It feels almost like people don't have the time to faff about. They want to know where the evidence is and how they can quickly put that in. We have published, some of you may have accessed them, something called the digital playbooks, and they are at the specialty level some of the best examples of tech supporting healthcare across the country. They cover things from mental health to cardiology to dermatology. They've had 140,000 views. They get about 12,000 views every week. People are looking for what works, and I think that's incredibly helpful when we're trying to scale at such a speedy degree and at such a pace. Around 3/4 of NHS time and resource is spent in the management of long-term conditions. And sadly, a lot of that is in the complications of disease and hospitalisation. And most people who are in hospital are there because they have an exacerbation of a long-term condition. It's around 70% of inpatient beds have people in that position, which is why it's exciting that digital tools that help people with long-term conditions like chronic obstructive pulmonary disease and other chronic lung diseases like heart failure are really starting to get traction in the NHS. And if you'd like to hear a patient talk about his experience of getting his control back of his life and staying well clear of hospitals, thanks to some fantastic community cardiac nurses and a digital tool, then please listen to Barry James talking on episode 2 of our podcast, the Innovation Collaborative podcast. And if the system works, there are some tweets going on as I speak with the links to these things, so you can pick them up afterwards. And what do you think the most common long-term condition is in England? Any guesses? Very quiet. Diabetes is high, but it's not that high. About 4 million people have diabetes. Another 2 million have got a blood glucose level that's saying they're getting towards that. And then there's quite a lot of people in the pre-diabetes risk categories. But Diabetes diagnosis, just under 4 million, so that's not the biggest. Yes, somebody said high blood pressure, yes, hypertension. It's estimated there's 12 million people living with hypertension in England, and 5 million of them don't know they've got it, right? Symptomless disease doubles your risk of heart attacks and strokes and vascular dementia and all sorts of things you really don't want to have. In fact, if you're over 40, the most evidence thing you can do for your health is to know your blood pressure numbers and do something about it if they are high. So it's an enormously large disease, and it's also on a very sharp socio-economic gradient. So what we would love is all 12, well, first we'll have to find all 12 million, but everybody with a new diagnosis of hypertension to have a conversation with their GP about home monitoring and sending their results in to be reviewed. We've been working with a cohort of GP practices to do exactly that. They have seen a tripling of the numbers of patients who are home monitoring and a big increase in the number of people who are staying in range, often with lifestyle advice, not necessarily medication. And as part of the work, we've also bought a load of blood pressure monitors so that GPs have been able to give them to people who couldn't afford to join the programme without it. And we now have 90,000 such blood pressure monitors out there in people's homes. And to return where I started about the power of bringing the hospital to people's homes, it's really interesting that NHS staff too are enjoying this new way of working. They tell us they find it tremendously satisfying keeping people where they want to be, and also they're able to do individual one-to-one nursing care. One of them described it as proper old-fashioned nursing care, which is quite ironic, isn't it, when it's via a video screen? But that's how she felt about it. And Sam Higginson, who's the chief exec of the service that you just saw, said that we've yet in 9 months of operation to have a single day of staff sickness on the virtual ward. Supervision can also be done from home, which gives a real flexibility to clinical roles, and could also help with retention by attracting people to stay in those roles where they can still give care but in a new way for longer, which would be terrifically helpful for the NHS. And this model of care helped enormously with COVID at home during the pandemic, but it's capable of doing so much more than that, because it gives people the information they need to manage their health to best effect, and by sharing results, it helps them better stay in control and spot the things that may be triggering them. It's really empowering and quite a helpful shift from perhaps the old patriarchal approach. And it's clear that it could help many more people across many more conditions beyond COVID, which is why I'm delighted that it's being supported to scale across the NHS in England. The NHS Planning Guidance came out in December. Essentially, they are the instructions to the NHS each year, and it outlined a major ambition to make virtual wards available to many more people across the NHS in England, committing significant funds, just under £500 million over 2 years, including £200 million in this financial year. My team is involved in supporting trusts to establish and then expand their services, and we've built a great peer network, sharing resources to help accelerate this work to best effect. We use, Eric Topol said during the course of last year, share more and get smarter faster is our motto. And there's a lively community where all essential information, documents and slides, business cases, standard operating procedures, essentially no one needs to start from scratch with any of this stuff at all. It's called the Innovation Collaborative for Digital Health, and it's open to all. There are record numbers of people waiting for NHS care at the moment, waiting for outpatient appointments and operations, and we're also seeing quite a lot of delays coming into the emergency departments. The NHS is likely to experience extra demand linked to COVID for years to come. Through supporting much more digital home care, not only can we help those with long-term conditions stay well, enable admission avoidance where possible, and help those who are admitted return home sooner, we should also expand the availability of inpatient beds for those who need them most, and to ensure that that is without delay. We now have just over 70 tech-enabled virtual wards across the country. It's an exciting time, and there is much more to be done. We see this as part of a real social movement in how care is delivered, with the patient very much at the centre and enabled to stay as far as possible in the place of their choice. My most recent blog on this is called Home is Where the Healthcare Is, as I truly believe that this is a paradigm shift that we now need across the NHS, and thanks to tech, can start to achieve it. So please join and power this social movement and spread the word that there really is no place like home. Thank you.